Okay, initially I would like to thank Professor Karamassis and Professor Philippatos for the kind invitation and really congratulate them for this very didactic course. I will go directly to the case just to gain time. We will present a 53 years old male patient which came to our center with an inferior wall STEMI case. From the coronary angiography, you can recognize quickly that there was a total occlusion of the mid-RCA, total occlusion of the proximal part of the left of the circumflex artery, a diffuse disease at the LAD, the ECG of the patient, and the coronary angiograms. It's easy to recognize that there were thrombus at both of the vessels, so decided to treat both of them. Just to gain time, I will say to you that we stented the right coronary artery and we used only DCB at the left circumflex because of the diffuse disease lesions. So there was a main remained question, the LAD, which all these plaques there, really were not able to decide quickly at the cath lab what to do with this case. So the patient came to us 3 weeks later. We saw that the stented area of the RCA was pretty good. And there was a very amazing improved lesion of the left circumflex. We could say that this is a new vessel regarding the pretty much result. The coronary angiogram again. And we recognize the tandem lesions of the LAD. So the question is how we could evaluate and treat this case. I could stop here and could discuss if you want some things, and I will continue with the final solution of this case.
Okay, Grigoris. Any suggestions?
Can you let the LAD coronary angiogram play in video, please, as we discuss? Is it possible for the LAD coronary angiogram to play live? So we can see it as it's moving.
There are multiple lesions.
Gregory, there is target for you for sure.
Diffuse disease.
I'll pass on the microphone because Dr. Angouras and I, we don't care about these tandem lesions. They don't bother us. So somebody else who's bothered by these lesions can discuss.
Yeah, when I heard diffuse LAD disease, I thought that I was going to see some really bad diffuse LAD disease. Yeah. But this is piece of cake for cardiac surgeons. Now the problem is how we're going to just do a cabbage times one, the patient who has already had his other two vessels fixed in the cath lab. Well, I don't know. I don't know in this case. Probably not, I would say. If this is, you will tell us that if this is nicely fixable with a stent or a couple of stents, I would probably go back. I would not insist in this particular patient. Although he's 53, so one of my old professors used to say, well, look, he looks like man in the bank. But which means that he'll come back probably in the future. But for now, I will ask my interventional cardiologist and see whether he can nicely fix this LAD lesion. I will probably.
Thanks, Professor.
We'll be happy to operate in 5 years. Yeah.
Professor Angouras, thanks for the comment. You could see the coin from the other side. You could say that, of course, for sure is diffuse disease, but you could say that there is a clear target for you, but we could say that the patient has always denied to go to another doctor because he said that Tsigkas did the best, so I continue with Tsigkas. This is real life. And we have to remember that we have, as you said previously, we have really a better technology regarding stents now. And if we face problem in the future, after that, the patient could come to you.
I think we should also discuss one of the things that was mentioned previously. I don't remember by whom, but one of the things that was said is that, if we put a lima to the LAD and the proximal segment occludes, we've lost some septals. As far as I know, that doesn't carry prognostic significance. I've never seen a study that shows that somehow if you lose the first third of the vessel, but you have a lima to the LAD from the midpoint down and it's patent, that somehow patients are harmed. And so that really has a lot to do with who we operate on, who we put stents on, all of these things, because that was mentioned as somehow one of the limitations of the Lima LAD. And the Lima LAD is really the main reason why cardiac surgery is preferred to stenting in a variety of scenarios, right? PCI is a wonderful tool. Many of us here, unfortunately, in the room will receive PCI ourselves. We know this in the future. And we always think as cardiac surgeons, if it occurred to me, what would I want? But let's not lose the sight of the fact that CABG has been shown to improve survival in a large number of patients, in a large number of patient cohorts, whereas this has not been shown for PCI. I think it's one of the overarching themes. So when we talk about a 50-year-old, before you were talking about an 80-year-old, you said you just wanted to make him feel better. When we talk about 50-year-olds, we really want them to live long. Now, if other vessels have been stented, I agree with Professor Angouras here that we probably continue with dealing the same hand. But if this had not been stented, the previous vessels, then we would be really hard-pressed with this patient.
Okay, Grigori, what do you...
Gregory, in theory, you are right, but again, based on the technology of current stents, you could say that with the open cell technology, this is not very common to lose, at least you could say, great branches.
What you did with your case?
Okay, let's continue with the case. So we used wire technology. We used the IFR just to start initially with that. And we took this value. This is really a pathologic value, 0.82. We used the pullback just to see where exactly we could stent this diffuse disease. But I could say from this line, it is not very clear what to do. So we went to Delphi, I could say, and I used Pythia just I could translate that technology with it's based really to, as Dr. Bouradas said previously, we used geometry, we used angiograms to do this technology, to use this technology in everyday clinical life. The virtual stenting helped us to use 2 long stents with this result. And because I said about estimation and prediction, you could see that the IFR estimated with this machine, it was 0.93. So we put 2 stents there. This is the final angio. It's pretty good, I could say. And this is the final result with this amazing post-stenting with the problems I said previously regarding what it means, IFR post-stenting. Exactly what the machine predicted, 0.93. For conclusions, I would like to use this slide. This is a very recent randomized study, the ILRD, concluded that patients with sequential long diffuse coronary lesions using this technology led to, I could say, better stenting, but this is a common problem regarding physiology studies. We face more MACEs or more TVF or TVR, I could say. This is something we have to discuss more. Thank you very much.
Of course, you apply this technique, but in your case, you stented the whole vessel. So
half of it.
You got the information just to help in your decision, but I think it was obvious from the angiography that you would need 2 long stents instead of 4 small.
Okay.
Spot stenting that the Italian group used to do some 20 years ago.
Professor Alexopoulos, we played with the lines we take with this machine, and we saw that the best value was 0.93 using 2 long stents, really.
So 2 things. Number 1 is a 53-year-old male. So the most important for us is also to save the space in the future if the patient is coming back to get revascularized by the surgeon. That is, since is one of the priority. Today,
if he comes back.
Correct.
At
correct. He was mentioning.
At this stage, okay, do a PCI, and if he's a little lucky, he could go ahead 90% of the cases without surgery.
For life.
But
for
if you
50 years.
If you have a really diffuse disease, this is sort of a price that you need to be paid and to anticipate in advance. So I think that is very important. Also, when we decide to fix with a stent, And especially in diffuse disease, we have other options, despite the fact they are not very well explored. Likewise, the drug-coated balloons that can save much more in the future the distal segment of the vessel, especially when you have diffuse disease. And this is a very important growing aspect everywhere in the world. When you are working in the Gulf area in India, you have on the table patients of 25, 35 years with extremely diffuse disease. Means that you cannot find one segment where you can attach the Lima graph. And of course, it's becoming very difficult to say, go ahead with aspirin and statin if they have a chest pain. So one of the open questions in the future is, can we develop new approaches or pharmacologic or mixed pharmacological intervention to treat better diffuse disease and, for instance, to reestablish a little bit of the compliance and leave the flow to get some better survival for the younger patient. That's, in my view, is one of the most important.
Okay, thank you. Dr. Milkas, let's hear your proposal.